All right, for the next hour, I am your mediator for the panel discussion. As these guys take their seats here, I did move you around a little bit. As these guys get situated, I'll introduce myself, and then we'll go into introductions for who your panel is as we wait for Mr. Will to come on up. My name is Nick Smettle. I've been a therapist since '97, and I've actually, since '94. I've been with Doug since '97. I started as a TA, and I've been an instructor since 2002, so that's kind of my background. I have a practice up in Cedarburg, Wisconsin. So I was talking with some people earlier about the longest drive here. I don't have that. It was about 5 hours. Giving the lady trouble in the back who drove 8 whole miles to get here. So can you raise your hand, please, so everyone knows who to smite? Yeah. 2 miles away here. All right, so I'll introduce these guys, and if you guys can give just a couple of minute background on your kind of experience and why you're on this panel. We'll start with Seth Will.
I'm Seth Will. I'm an instructor for these guys, the seminar organization. So I'm a massage therapist, so here we go.
And I'm Jan Keener. I'm from Ohio, Cincinnati, Ohio, and I have been a massage therapist since '94 and kind of following Doug around shortly thereafter, and been an instructor for 10 years or so. My background is in teaching. I was a teacher before, and I teach the head and neck and the upper extremity, and so a lot of you look familiar to me. It's great to be here.
And Kathy Myers.
Meyer, no
Oh,
S.
Meyer.
I'm Kathy Meyer. I live here in Champaign. I run a practice out of my home. I'm an athletic trainer. I've been practicing athletic training since 1984, massage therapy since 2003, and I've been PNMT certified since about 05, 06, somewhere in there, and just started teaching this year for Doug.
And Julie Nichols.
Hi, I'm Julie from Cincinnati, Ohio. Took my first PNMT seminar in 2001 and started teaching in 2007. And as was mentioned earlier, it's great to see a lot of familiar faces from the seminars and meet some new people as well. And we're going to have a lot of fun.
And Beth Maddox.
I'm from St. Louis, Missouri, and I'm a physical therapist since '89 and a massage therapist since '02. And I started in a major medical center and then a chronic pain clinic, and I have my own practice now by myself. And I'm glad to be here, and I just started teaching about a year ago.
And Laurel Finch.
Hi, I'm Laurel Finch from Springfield, Ohio. I was licensed in Ohio in 1990, and I started studying with Doug in '94 and assisting teaching, and I do have 100% clinical practice doing PNMT, and I don't know why I'm going and so many times. That must mean I have nothing more to say.
Christine Erickson.
I'll take it. Christine Erickson, and I'm living now in Denver, Colorado. I've been a massage therapist since 1996, and also studied with Doug that whole time, pretty much, on and off, and became an instructor for precision neuromuscular therapy in 2004, I'd say. The clinic that I work at now is a small, private outpatient clinic, and I also got my physical therapist assistant degree about a year ago, so incorporating in the neuromuscular therapy and the physical therapy setting is great.
Great. Thanks, panel. We had an online poll from the peer group, the people who are going to attend the colloquium, to raise questions, what you guys wanted to talk about on these panel discussions. So there's a couple of things I want to share about that poll that'll target our questions, but I want you to pay attention to a couple of things. I'm going to address the panel, and we'll ask these questions from the online poll, and hear a couple respond, and then we're going to throw some things out as far as what you guys thought about their responses, if you guys have anything to, any other input. It's important to realize a couple of things. We're a peer group here. Just because these guys are on a panel doesn't set them apart necessarily, except for the fact that we represent PNMT, all right? This is definitely a room of peers, so we want to really emphasize that your participation, especially in this panel discussion, will help to give it some depth and breadth. So another thing I want you to really focus on is listen to the different responses, not necessarily the answers as far as a competition, who's more right or wrong. Listen to the approaches. If anybody knows these people, you know, Seth's answer is going to be dramatically different than Jan's answer, all right? And not necessarily...
Can't always be
Yeah, what is that supposed to mean?
Excuse me, I'm the moderator. We
Basically the
moderated.
same person.
So what's important to emphasize in this discussion is that everyone's approach is valid and we need to respect that, but to understand that we're not looking for an answer, meaning that there's a competition between us or you. It's the process we want you to be engaged in. And this is something that if you can kind of step back, and David alluded to this a lot of times with the idea of listening and communication, really listen to how they go about their answers. These questions that I've chosen based on the online poll, the two top kind of directions that you chose. Number one was basic clinical reasoning. How do I know what to treat first? Okay, so this is one broad umbrella that we're going to use when I choose specific questions. And number two is redefining massage therapy in the eyes of the public. All right, so these are the two main things that you guys chose as far as your responses to these online polls. So getting specific panel, and as long as I picked on Seth and Jan, you guys can answer this one.
So we always get picked on?
Kind of
Are you gonna
two-
share it around?
Two questions here, for 2 parts really to one question. My biggest issue is, what do I address first, especially if that issue seems to be many different muscles and maybe even a form and function issue, but more specifically the question is, how do I know which complaint or which muscle to address first? This can be challenging to me, especially when it's part of a complex interaction between muscles.
I want to go because I have an answer to this. For me, and this came from Doug, that the client is the one who has like the benchmark. Not necessarily, of course, you know, I want greater range of motion, but when I dry my hair right here, it doesn't hurt. So I let them tell me what the benchmark is, and that helps me not get lost in all the other things that, you know, I'm getting, you know, I see, oh, this or this. So I let them name it, and then that clarifies my goal.
Seth, what would you say?
I mean, it's tough as far as like superfluken, that's what I call them. When he was talking about as far as, you know, getting and figuring out as far as what the patient wants out of the session, I mean, that's super important as far as, you know, I'll give you an example. I had someone that came in and I've got these little charts that they fill out, and on there, the first thing that they filled out was high right shoulder, no pain, and then they had all these other things that had pain, and so my assumption was that they were coming to me because they had pain, but their number one concern was that they had a high right shoulder because their chiropractor told them they had a high right shoulder. So, you know, I treated their pain and, you know, went completely away, but the guy was kind of pissed. He's like, my shoulder's still high, you know? So as far as, you know, figuring out exactly what it is that they're coming in for is really important. But beyond that, as far as you've got a complex issue and you've got all these different factors that are involved, I mean, assessment is one of the number one things that's gonna be able to narrow it down. You've got all these different possibilities. The more that you know about assessment, even beyond the seminars, that is gonna be able to, you know, kind of help you, you know, kind of zoom in on what's gonna be the most important aspects of it. Tomorrow I'm gonna be talking about some of the concepts that Carl Levitt called kind of key links, you know, so often there can be, you can look at an entire pattern and often there's, you know, one major area. This is kind of interesting. He was, a guy that worked with him was interviewed and he watched this guy practice and people would come in with like scapular issues. And because Carl Levitt, you know, he's still practicing in '93, you know, a really renowned neurologist, he would see people and he would just do his assessment. He would treat based on his assessment. And people could come in with a scapular issue and he might mobilize their fibular head. And he's like, every single person he treated got better. You know, so as far as he understood the system enough to where he could figure out these kind of complex interrelationships and find these key distortions and treat them. But bottom line, you got to make them feel better before they wind up leaving. So in any way that you're able to do that, initially, it's figuring out, you know, what is the first thing that's, you know, what's the most troublesome thing that you have that you want me to deal with? And then by whatever means that you know right now, in some way affecting that in a positive way and having some sort of credible explanation to that, that's the first thing, first and foremost. I know Travell was very big as far as, looking at posture, making people comfortable in chairs, checking out leg lengths. I'll never do that until a couple times down the session if symptoms start coming back in terms of perpetuating factors. So I won't look at those things first, and it really comes down to kind of treatment philosophy. Everybody's got to develop their own treatment philosophy. And for me, the first thing is ultimately dealing with that primary complaint that they've got, that they come in with, and narrowing that down is really assessment. Beyond that is where I start adding other things in. And usually that doesn't come until the second or third treatment.
Thanks, guys. What do you guys think about that? Remember, the question was, I have difficulty knowing which complaint or which muscle to address. All right, what do you think, Sarah?
One of the best answers that I've heard given to this question at a seminar that I took with Doug was, the one I know I can make feel better. And the reason behind that is if there's 2 or 3 pain areas, if you make them feel better in one of those areas, they'll be back so that you can treat the other areas. And if you're not as knowledgeable in those other areas, it gives you time to research those other areas.
Great. Nice. Who else has some input? Questions or comments? Yeah, Glenna.
Kind of what I work on a little bit with that too is what activity do they want to get back to doing? Or maybe it's just a good night's sleep or something like that. And if you could, work on, hey, get them to just relax them enough that they'll have a good night's sleep and sleep through the night, they'll be back as well. Or what activity, they want to go out and play tennis, but their wrist hurts or something like that. Work that particular area or that kind of thing. They can go out and play. They may still recover, have it come back, but they'll come back to, if you fixed it once, they'll come back again, and then you can work on something else and further from there as well. So.
And then also, I can't remember where I learned this, but I think probably, if something's involved in several things. So if you've got a complex pattern going on and there's one thing that's part of this pattern and part of that pattern and part of the other pattern, that might get you the biggest payload of results first time out.
Anyone else have some feedback there?
I was going to say what you said, as part of the clinical reasoning process in deciding which muscle can have the biggest impact on all of these things that they say. So, if it hurts to turn to the right, and it hurts if they're leaning over too much, and it hurts when something's hanging over their shoulder, you'd say, oh, the levator scapula is involved in all 3 of those things. I'll start there. But one phrase that I like is collaborative reasoning. And that's clinical reasoning is when you decide which muscle am I going to select based on the signs and symptoms. The collaborative reasoning is we say, let's decide on what's important together. So I always find out, in addition, I like what Seth said, and what Jan said, what activity would you like to be doing? What do you want to get back to? And my favorite follow-up question is what types of things will tell you that we're getting there? So that they say okay, I know I'm feeling better because this set of things will happen. And then, the range of motion stuff, I've never known anyone to care whether it was 160 or 170. That's for us to care about in our clinical reasoning, but to find out more what the person cares about is probably at the heart of it. But that's collaborative reasoning where you decide together what is important.
Great point. Great. Any other feedback on that question? Well, let's use a little collaborative reasoning now. Is this relevant? Is this relevant to your practice? What do I treat first? How do I know where to begin? Okay. Did you notice a difference in responses here as far as approaches? There's no one right answer. All right. So you need to kind of listen to people with more experience and then develop your own answer to that question, your own modality there. Next question.
Nick, can I say one thing? It's part the notepads that are on your table. If you have a question, just pass it towards me or just kind of wave it. These are questions that we did with the online poll, but that was just a starter thing, and I was kind of hoping that some of you would have questions. So if you have one, just jot it down on the notepad and just kind of wave it. I'll come around and pick it up. I'm the runner, okay?
He's working for me now.
That's right. I finally found a job I can do. That's right.
Let's hear from Kathy and Julie here on this next one. And again, a two-part question. The difficulty is that clients don't know, and some don't want to know, the art of science and massage therapy. So how would you build rapport or respect with clients to better affect change in their symptoms?
They don't understand the art of science, and we need
They
to.
don't care.
They don't care
They
about
want-
it.
yep.
Okay. I basically, I think that comes with experience, and the longer that you do something, the reputation that you gain, then you gain their respect in terms of your opinion when you tell your clients the things that you want to tell them. And it's a prerequisite in my business when I see someone that they're going to learn a little bit about anatomy, and they're going to learn a little bit about the body and how things work. And it's always a part of my treatment, and I explain that to them right off the bat, that this is interactive. I want you to understand how this works and what the science is behind it. And it doesn't have to be an in-depth instruction, but I just explain that to them right off the bat, and that it won't be as effective if they're not aware of how their body works, whatever that injury may be, or that issue or that pain issue may be.
Yeah, and I don't think that you necessarily need to get super technical with people, you know, in terms of anatomical terms, things like that. But in the same way that each of you know that we all have different styles of learning and ways of approaching things and understanding things, clients are the same. So I like to use lots of different avenues to help with that understanding in terms of having pictures, and I have a full-size skeleton, and showing the movement with my own body and taking them through a certain movement. So depending what kind of learning style they might have, that will give them a little bit of insight into what it is we're doing. Because I do find that people, even if they think they don't care, once you start creating a change, they do have this sort of desire to understand how that change is occurring and maybe why it hasn't occurred before now. What's different now? And I think people have this curiosity that there are lots of different ways that you can help open that window to understanding for them.
And discussing what the end result might be. This is what will happen if you have a better understanding of how your body works when you do this movement. I work primarily with athletes, so most of the time they want to know what's going on with their body, but talking to them about this is what you want to do is run a marathon in the next 6 weeks, and this is where we got to go with it. This is how you have to understand this part works, or whatever that may be.
So what do you guys think? And again, the question is, how do you build this rapport or respect so that you can help people change their symptoms? Mike?
Well, I think it's also important to try to explain to them that what we do in a half an hour or an hour session with all the other hours in the week is really going to have a limited impact if they don't get involved in the process.
Kirk, you had something else to say?
Yes.
I think sometimes when you're talking about how in this kind of situation, it's very important to understand, maybe get a basic concept of the 4 different personality types, because how you're going to talk to an expressive versus how you're going to talk to an analytical, now, that way you can choose, because, or this is your type A personality, what's the bottom line. If you go into this whole analytical thing, with Seth, with his plethora of knowledge. Yeah, not that he would be analytical or anything, but, if you're talking to a type A person, he's like, yeah, what's the bottom line? Boom. And they could care less so you have to put it in different terms. So you got to speak to them in a language that they understand.
Being as I was pointed out, can I chime in? Okay. And I'm sure Fluky's going to follow up on this as far as, and this more has to do with just as far as explaining the process as far as what we're doing and the whole idea as far as what's important as far as the client to understand in terms of the kind of, we talk about anatomy and physiology and things like that. Ultimately, like you said, you've got to be able to express it on their terms. All right. Often I'll use metaphors unless specifically they ask, physiologically what's happening. Outside of that, I'll never wind up using that. And I might use a metaphor that I have developed, but I'll often try to figure out if they're in a particular profession, whatever it is, I'll try to figure out a metaphor that's more relative to something that they understand. So as far as, me going through all sorts of neuroscience and neurobiology and stuff like that, most people don't give up, and it's, and the whole thing is we've kind of experienced, me and David, as far as groups of therapists that are very big on explaining things to clients, and that being a major process, and it's an important process, but how you go about doing that, is drastically different in terms of, what they're actually going to get out of it. A lot of times it's just, that makes no sense to me. It's completely irrelevant. Why are you telling me that it's in the brain? Because I have pain here. And even though, pain is a perception through the brain and on and on, that helps them zero. So if you're able to give them something in some manner that they're able to understand, however that is, and typically for me it's an analogy, it's a metaphor, it's something that has honestly nothing to do with what I would explain in a classroom setting, that's typically what I'll wind up using. That seems to be most effective. And again, something that they're gonna be, more used to. And something that would help with that is watching stuff like Discovery Channel. Everyone watches like, Deadliest Catch, or like, at least I do, or Axemen, with Lumberjacks, and, things like, so like if you're able to relate to something like that, a commonality, then, people start to understand, then they get on the process, and then they might ask questions more. And so, Fluky, you got anything more to say?
There's someone back here, Nancy.
Axemen is filmed in Florida, by the way, and
Yeah?
I have a client who knows those people personally. How about that?
That's amazing.
Where's my bingo?
That's it, swamp people.
Can we teach in Florida?
One of the phrases that I picked up like about 5 years ago that seems to have that like Scooby-Doo thing of was, there's 168 hours in the week, I have you for one. What you do for the rest of that time is up to you. And all of a sudden, they come back and like, did you really count the hours? Took off my shoes and did it, but it gets that thing going of, oh yeah, okay. And we talked this morning about, what are they gonna do in those 167? What are you doing in your life that causes that to come back? And all of a sudden they become more body aware and they write you more checks. So that's it.
Did you say 168? No, I'm just saying, I could imagine them thinking, wow, this neighborhood watch program is going too far, right? That's great. Anyone
Any
else?
other input into that building rapport and respect in the office?
I have one other thing to say. If you can relate to the activity that they're involved in, that really helps. If they're, whether they're an athlete or they're in some type of business or whatever activity that is, and talk to them and communicate with them about their activity and say, talk about scoring or offense and defense and different positions and that sort of thing. And then they're like, oh, you know this sport, huh? And then you start talking about that and you say, well, if you want to do this particular move, then you have to be able to work this particular muscle in this way. And it does help if you understand the activity that they're in and can communicate that with them.
Yeah. Following up what she was saying, I've worked with clients that it's like, oh, I have this chronic pain. Okay, da-da-da. Well, maybe they go on vacation and it goes away. And then they come back and it's like, oh, it started up again. And it's like, okay, now what was different? And it's like, oh, well, I wasn't driving. Oh, okay. Or, oh, I slept in a different bed. And it's like, okay, now what can you do to change this now? And if they don't, it's like, well, did you get a new mattress? Well, no. Or did you get a new pillow? Well, no. I go, well, you got the choice. You can keep coming back to see me, or you can make these investments. And then it puts it on their part too that, oh yeah, so I need to make that decision, or, no, I haven't been doing this self-treatment at home. And they respond to you more because, okay, you've both agreed what a causative factor is, and then it puts the ball in their court.
Let me get that to Michelle here. You got more? So I'll get you over there.
For those of you that know me, you might find this unbelievable, but every now and then I actually don't try to, like the first few sessions, just respect that maybe they want to just be taken care of because they've been working so hard to go through physical therapy, or, if I understand that that's what they're saying, and actually do just take care of them. I believe exactly the same as you do. We only have their bodies for an hour and they have it for the rest of the time, but actually to kind of develop that through your hands, because that is sometimes, we forget, like love to educate now so much, my clients, but sometimes we can speak through our hands. And that study that Doug had a study, was that 2 years ago? That was done at the University of Illinois with the stress. But I thought that was a good reminder sometimes that by just letting them be silent and, I know it's hard to believe, but, go through a few of those treatments and do just take care of them and respect that. And then kind of that builds a rapport where then you start to get to know all these other things and start to educate them slowly. But I've oddly found that to work.
Let's take one more with Gloria here, and then we'll move on.
chocolate.
This, as everybody was talking, it just dawned on me that, you know, there are some clients who you have to understand where they're coming from if they say, you know, I just don't have time, you know, to do this or that, or I can't change this. These perpetuating factors, that's just the way my life is. And so then, you know, that becomes a time to be sympathetic and caring in that way, but also be able to provide some maintenance for them. And they, you know, some people are, they realize that that's just the reality of the situation, that maybe it is a maintenance issue. And, you know, they figure out how long they can get relief, you know, before these perpetuating factors, you know, make the situation go back to what it was. And so sometimes that's just the reality of it. So that's just a different, thinking of certain people, you know.
Gloria, this is perfect here. So remember, the question is, how do we build this rapport and respect? And then Gloria raised a specific example of they have to go back and do the offending activity over and over again. So I want to present this question. You guys can feed off of this a little bit for the last three here.
Hey, can I say one thing? Just one.
Oh.
So, you know, I had a client once, and I sort of get this because my mechanic seems to love to bring out car parts and explain like all this stuff that I just don't care about. You know, it's like, you're talking to the wrong person. You know, I just want to get in the car and go. So I sort of get that as much as he's excited about it. But, so I had a client once who said the same thing, you know what? I just don't care. And then I flashed back to me and the mechanic and thinking, I get that. So what I told him is this: I know you don't care, but you need to know that I know, right? That I know what I'm doing, and I care, right? Just flipping it around. So I know what I'm doing, and that can all happen in silence, and that I care, right? And that's the respect part.
Awesome. So let's apply that to this situation, ladies here. So in this situation, someone has chronic shoulder issues for a decade, for 10 years, like subscapularis trigger points is a guess. Deep chronic pain that is stabbing in the back under rhomboids. Okay, so this is specific. I like to just watch their brain start to work right away. Now, here's really, I think, the important part, and I think what's relevant to what we were talking about. He really wants to get better, but it's his work that's the problem. Part of the activity that keeps continuing this pain is he has to lift a 30-foot ladder and carry it to homes every day. He's a roofing inspector, and there's no way to get him to stop this because he owns his own company, and this is a busy season. You can go into what you want to treat, or what do you do with that?
I have plans like that. So let me see.
Sure. Laura, just a second. The symptoms were chronic shoulder issue for 10 years, seems like subscap trigger points based on something, deep chronic pain, stabbing in the back under the rhomboids, deep too.
So is the question, what do I think it is, or is the question, how do you work with the dynamic of I have to still do what I do?
As long as you brought them both up, how about you answer both?
Well, I'd have to evaluate them to see what it is. I can't say it's subscap right off the bat, but with the issue of this is my job, this is my livelihood, I have a patient who was told you need to just, she was pipetting in the lab a lot, and that was the issue, but she's a chemist. You know, you can't just go be a salesman or something else. You know, it took a while, and she was looking at that for years and finally got into a desk job that doesn't involve the pipetting. But in the meantime, we taught her how to take care of herself in that job. And we tried to manage the symptoms as best we could in that job. And communicate with her about her job and the techniques and everything, and see if we could make it ergonomically better for her. And just try to manage it along until she eventually got into a different job.
I do have a number of people in that kind of situation, like mail carriers that are doing the same motion day after day, long hours, roofers, factory workers. Not as many factory workers left in the United States or in Springfield, Ohio right now. But there's a couple things right off the bat. Is it changes my expectations of how they will respond to the treatment and my expectations of myself as a therapist, of what I can accomplish. So it reframes the expectations. And I have compassion right away. It's a sad story when somebody is either stuck in sometimes they're stuck in a position. Sometimes it's their vocation that they have passion about and they love, and that happens with musicians too. They very much want to be able to continue this thing. So I feel like it's my job to go to bat and try to find ways around it. And one of the things I want to work with them on is what are the factors. We can't control the demand in their life so much of the particular activity, but there are other factors that we might be able to have control over. Like if they're at the computer 12 hours a day, they can stop, even though they're doing these small static movements with the mouse, they can stop and retrain themselves to every so many minutes, trace around the ceiling right and left and trace around the floorboard so that they're using more larger groups of muscles, because sometimes those static movements are a problem. So, I mean, there's examples of, okay, where could we find the thing that could be variable? Can you take more breaks? Can you do more variety in between? Can you stop every time that you put that ladder up against the roof? That might be a moment to do a particular stretch. So I'm going to be looking for the things that are under control that could be mitigated.
I'm going to go also kind of piggyback on it changes the expectations of the therapist and the client at that point. I become also very sympathetic to their situation because it is what it is, and that's what I tell them. You know, we're not going to change the demand. We're not going to change those things. We can modify things. We can make your system operate at a more functional level. So what I'm more interested in is recovery time when they do have episodes. This is a situation where I would support maintenance programs in massage therapy. They need to be diligent about the movements and exercises that counter what they do all day, right? So, you know, if they are lifting, you know, up here and everything is forward, you know, maybe it's laying on a half roller to extend everything back using, I mean, there's like little toys and stuff that you can do with that. So that when they, you know, when they leave in the morning, you know, their movement patterns are well. When they come home at night, that they repattern how their body is before they go to bed, right? And then that they get on a maintenance plan for massage therapy, neuromuscular therapy, because there's going to be those certain things. And piggybacking on David's talk this morning, right, on the sarcomeres and coming together, right? That needs to be released because the load demands on that is not going to change. So it helps to have that conversation though with them so that they don't think that they're going to come in and get some treatment and then go away and go, okay, you know, I'm fixed and I can go. This is a long-term thing, and as long as they're doing the activity that kind of perpetuates that, it'll be a maintenance thing. And I look for recovery times that hopefully they can recover within hours or at least within 24, you know, the next day, right? That they can.
Great.
Can I add one sentence?
One,
just one. There's a whole lot of different ways to carry a ladder. Does that need more explanation?
And that's what I was going to add on is, you know,
Yeah,
not only is it the repetition of the activity, but how are they carrying the ladder? Are they always doing it on the right side and the left side? And looking at how they compensate, because people do a lot of abnormal behaviors and motor patterns they're not even aware of. You know, well, the reason you have all that shoulder pain is because you do this really weird thing when you lift the ladder of hiking it. And if you didn't do that, you might have a little bit less pain and we'd be able to keep you at a lower chronic level than, you know, 7 out of 10 we can maybe keep it 3 or 4, which is better. So assessing those activities and not just the modification, but how do you do that task and how are they compensating can also relay in.
Great point.
This may be
Gloria?
manageable, but not curable.
I would say, as far as all of this seems to come from the idea that we're assuming one thing or another. So if the mattress is seeming to make the back pain worse, well, what if it's not the mattress, you know? So then as far as occupational hazards, the goal would obviously be to let them continue to do this thing that they obviously chose as a profession. And athletically, if it's a repetitive stress injury from sports, you'd want to kind of, you really don't want to have to ever tell them that I don't think you should do this anymore. I don't think this isn't good for you. What happens when they give that thing up and they still have this pain and they're like, hey, you know, now I'm even more frustrated. And so I would just say that I feel like it all came from this chain of questioning, but you can't assume that this is for sure the only reason why they're in this pain. So.
Kind of piggybacking onto that, sometimes they just think they're going to walk into your clinic and you're going to say you got to stop and you got to change your hobby or your job. And sometimes just saying, I hear what you're saying and this is something you want to work around, sometimes then they'll back off and say, well, I really can delegate this or I can break my day up. They'll give you a little more breathing room sometimes, but they just want to hear you not say you have to stop that because they're anticipating that.
Yeah, can I just say this is the best thing I've ever seen in a seminar because I'm loving this. But to piggyback on what Jessica said, like we've all been talking about, yeah, we're all piggybacking. But we're all talking about like ergonomics and lifestyle, and maybe it can't change. There's also like the other categories, like the person who wrote in said subscap, a sharp stabbing pain in the back. Why not a rib dysfunction and try to hit a home run? Because maybe it is something with the carrying of the ladder. There's some sublux rib or a levator costorum spasm, something that you haven't considered before that has everything to do with it. And so who's to say this thing is permanent until you've explored all the possibilities? And not to give false hope to someone who suffers for 10 years, but you say, you know, I like to say to people, whenever they name whatever region, well, you know, there's like, I can think of 5 or 6 different reasons why. We'll pick them off one at a time and you tell me what's working. So that, I think there's also a call for just more education too.
When people ask this, I usually end up talking about, or when you have that situation, from the stress of life on Selye. He has the definition of stress, and it's the disparity between the internal environment and the external environment. And so looking at it that way, well, maybe they can't change their job or this thing they do in their job, but what other things can be changed to create a better environment, reduce neurological inputs, whatever, you know, other things that you can change. There are usually some things you can change.
Right. Michelle?
I think I might have heard Beth maybe mention it once, but it might be good to mention again that if it is their job or their profession that they have to go back to the next day to be, and generally in the first treatment when you're seeing someone, you're being a bit more mindful of the pressure and how their body will react, but to really be mindful to not overdo it or overstimulate because they do need to go back to work and you would like to see them again. You know, if you piss that area off, that's it. Like, which in some times you can do that with a person because they realize you've got the spot, but with someone that they have, that's their livelihood, they can't go into work the next day. You know, it's just to be mindful to stay back. Again, it's telling myself that because I like to go in, but.
Great discussion, great.
Yeah.
Let's try to fit a couple more questions in here before we have to wrap up. I've got 2 here that I really want to get to. I guess one, maybe I'll open up to the whole panel initially just to see what you guys have to say. This regards research, and we're trying to look at research in 2 different categories. There's the modern medical world, okay, and when I think about that, I think it's mainstream, it's respected, it's normative, and most importantly, I think it's funded, all right, medical research. Compare that to what we do, the kind of research that, Doug's compiling through us with this group. What stands out there? It seems a little more applicable. Obviously, we're biased here. But the question is, how can we mesh these two research divisions or perspectives to be more relevant to mainstream thought and application?
Okay, sir. I guess, this is online. This has been a big argument back and forth as far as people talking about, doing evidence-based work and, trying to base all our therapies on studies that had previously been done. And honestly, I've got so many issues as far as the way that those studies that have been done. I think if I based my therapy on the studies that have been done, I'd be a pretty poor therapist. So as far as the way that I approached it is, it's evidence-informed therapist, not evidence-based therapist, because it's like I've seen so many different studies about as far as reliability of detecting trigger points. You'll see a one that it's incredibly low to be able to detect trigger points in between people, so why should you ever do that? Same thing with very specific techniques. It's very low inter-rater reliability, so why would you ever assess for something very specific? But it's like, who did they choose to actually do those? Did they use somebody that was actually experienced? So I've got so many issues with the studies that have been done on that there's just so many different factors. So that the whole thing is, one, just understanding how they actually did that research, and understanding that the way that you can take and understand, interpret, and use one research paper can go in 100 different directions. And I can give you like one example of, there's a famous pain researcher, Ronald Melzack, right? So he's got this neuromatrix theory, right? I interpret that one way, and a number of other people I know interpret it completely different ways, and all of us wind up utilizing it in our practice completely, in opposite ends of the spectrum. So the whole thing is, I said before, as far as everybody develops kind of their own treatment philosophy and how it winds up relating to how they want to incorporate it in their practices and what type of practitioner they are, and et cetera, et cetera, et cetera. I mean, that's key. I mean, I always say, as far as like when I teach, I never want to see somebody doing the same thing that I did. It's one of those things you got to figure out something that works for you and works for your clients. And the more exposure that you get, the better you are, as long as you want to practicing continually and you reflect on that practice. And you have to do that for a long time. And the science can only help you as far as little pieces here and there change what you're already doing. But again, then you got to reflect on it as far as if you did something like that and you get it on a shot as far as practice it enough to where you can say, I'm competent at that, and then decide, is that effective? Is that more effective than the other way that I was doing it? You can't just like, decide, oh, well, I'm going to try this new technique because I saw it in a research paper and, I tried it once and it didn't work, so obviously that technique doesn't work at all. That's absurd. To be able to get good at something and realize that it has benefit, you need to give it some time, you need to give it some practice, and that's, it's not a quick process.
So Beth, what do you have to add?
I was just going to say that the little R research that they kind of talked about here that we do in our practice that is useful and applicable right now. My research involvement to be certified was like the smallest amount it could possibly be. It was not a big study or anything. I just participated with other people, but it decreased my intimidation factor. And so if you start with little R research and something that is not intimidating to you, just start somewhere. I think that's the vision of what Doug is saying, is there's just so little out there, but we have to start somewhere. It can be as little or as big as you want it to be. Start at your comfort zone. And it really does fuel the fire to say, well, that made me think of something else, and that makes me think of something else. So to jump from little r to big R, you got to start at little r if you're too intimidated or not experienced in research and statistics and not making it publishable. But the other thing is, my sphere of influence in research is I can then say, well, hey doc, I did this little study that shows, like the golf swing study or whatever, the hamstring study. I've seen in my practice, and I've done this study, and here's what we're finding. Anybody in your practice that fits the bill, I'd love to be able to help them. Hey, a doc is really impressed and has the intention of a massage therapist who is communicating with them about something they've studied scientifically that is important to them. Okay, and then taking it to the research symposiums like Laurel did, taking it to a bigger stage and trying it out there, you're getting the attention. of a bigger community, of a more scientifically based, research-driven community. So just start where you are and go with it, and just talk about your sphere of influence that you have.
I have something to say about that. Because I started with a small project for certification, and honestly, I picked the easiest thing I could think of to meet the requirements to get my piece of paper. You know, like a lot of people. I knew my life was busy. I knew that I had all these, well, actually, I'll back up. I had grand ideas, and every time I tried to do the design, it was just impossibly cumbersome. So I backed up and went, what is the simplest thing I can do? And I thought about measuring incisal opening. And in the course of doing the first study, it was just full of holes. It really kind of was, I mean, I did the research, I took a lot of measurements, I learned a lot. And the data, the statistics when it was processed was worth nothing. They canceled each other out. There were a lot of variables. I kept discovering the variables that were invalidating my research and all my time. And then, so that's where I started from. And then I got help from a math department in a university who, for their senior project, they worked with me. They were statistics majors. So we went through the IRB at the university, and it was overseen by the chair of the Department of Mathematics and Computer Science. And I also called in a physiologist who worked at Wright-Patterson Air Force Base in research her whole life. She's been doing research, grant writing, and writing papers. So I had a team then that could come in and tell me how to do it, how to design the project so that the statistics would be accurate. And in doing all that, I submitted it to the highlighting massage and research. That's an international conference, and I was invited to give an oral presentation. Now I had to go and give an oral presentation in a group full of people where I had witnessed day after day the scientific community, people from National Institute of Health, National Science Foundation, a lot of university research programs, and someone would stand up and do their presentation and the rest of the room would rip them to shreds. And I got to watch that. And then I got to stand up and give them another presentation. So I love sharing that as a massage therapist. Like, woo, you know, that was pretty big and scary, but it was very successful and very solid. But it was solid not because of me. I had the ideas, but I had the people to tell me, okay, this is how you do that.
Can I say two things? One, for the hundreds and hundreds of times you've done the intraoral measurements, nobody does it better, right? Because nobody's practiced it that much.
You do it hundreds of times.
And the other question that Nick threw out a little bit earlier, which we'll kind of deal with more tomorrow night, which is elevating this profession in the eyes of the public. Think about all the people who were involved in Laurel's study and who she marshaled to be part of that. Think of what their attitude and what their thing, and like Beth said, to physicians. I bet they think differently about massage therapy when you're floating that out, right?
Yeah. We've got about 5 minutes left. Right?
Yes, that's right. Did you want to
If
do
you guys
another
don't mind, I'd
question?
like to squeeze one more question because I think it's a little more target and stuff. I don't want to downplay that one about research, but what does everybody think about this? What are some of the most common conditions PNMT can treat that no one else does? And if I can add something to that, you know, what can we affect the easiest or the most? I look at that mainly from an income standpoint. Let's say, I think I've asked this question before, and let's say TMJ work is the easiest thing for me to do, but it's also one of the things that has the most dramatic, quick results. Whereas there are other things, say frozen shoulder, that we run up against that is just a hornet's nest to start on, and you know, you don't know if you're going to get results. So again, the question, what are some of the most common conditions we can treat with PNMT, and you know, what responds the best?
I'd love to respond. Are you calling?
Go ahead.
And I just want to say that the jaw muscles, the interoral muscles, there isn't any other field really addressing them, and it's fairly simple as far as the technique and very effective.
Sabrina?
My personal favorite has to do with whiplash and just being able to get such dramatic results through simple neck work. And that's, I love that part.
Other?
From the panel here, what do you guys?
Dina?
I'm a big psoas fan. I feel like back pain caused by psoas.
Remind me to stay away from you. Actually, I work with a lot of chronic shoulder injury. I get really excited when people come in, which freaks them out, which is great too. Like, that's painful, awesome. But I have found fascia to be just an incredible tool. If you can spend, and it might be an hour, it might be an hour and a half working on fascia, releasing, separating, but seeing their responses to it, especially over 3 days, and saying, yeah, I was noticing this or this and this, and I've never been able to move my shoulder like that before. It's that immediate, yeah, there could be other things going on, but they realize it.
Who else? Initial question.
Yep.
Kurt?
Oh, okay.
Following the theme of the day, to piggyback on that, is I think the shoulder actually is one because it's such a hornet's nest. And I think that's where people who have learned these critical thinking skills that, and being strategy-based instead of technique-based, that really puts us in an elite faction of our things. And because I have, at this point, especially after studying some of this stuff, I have a lot of other therapists in the area saying, Kirk, I got this shoulder that I can't do anything with, and I know that you have done this stuff, and can I send somebody over? So I think that's where we sort of separate ourselves from the herd, is with the hornet's nest.
Christine, Christine, do you have something to add?
Kind of. I don't know how to word it because of the question, but problem solving, kind of talking about with a couple of the responses is knowing it's not necessarily the condition, right, or the problem, but hopefully trying to problem solve through what technique I'm going to use for that issue, right? Because, fascial work is great for the people that need fascial work. If you're working on a shoulder and it's frozen shoulder, and it's been diagnosed as a frozen shoulder, and there's trigger points that restrict the motion, and you work some trigger points and you release that, right? Like, great, I just resolved a frozen shoulder in one treatment. But do you see what I'm saying? So my process in learning and being able to problem solve through what technique to use when, and by doing the assessments. Not only the muscle contraction, determining what if a muscle is hypertonic or if it's inhibited. And I guess I'm just going to take this little thing, because one of the things that I've seen in our practice that was a big eye-opener is inhibited muscles are just as big a problem as hypertonic muscles, tight muscles, right? But in massage, everybody is all about loosening up the tight stuff. And in a lot of what we do in our clinic, inhibited muscles are a bigger problem. And we can't, as a, say in physical therapy, right? You can't engage it by exercise. It doesn't happen that way. You do that through soft tissue, and you have to palpate, and you have to get it to work, and then get it to engage, right? So it's not the problem. It's
not that easy.
It's the big picture. It's the big picture, and then hopefully, like I say, using all the tools in your toolbox to be able to discern when am I going to use fascial work, when am I going to use more movement things, when am I going to use trigger point therapies, when am I going to use, kind of a gliding maneuver, when am I going to calm the nervous system down, right? I mean, it might just be a matter of, you know what, we need to calm it down and get that sensory stimuli to mellow out before I can even begin my treatment. Quote treatment.
Comment, then a quick question. I love me some low back. That's it. I'm the best at it because that's what you're going to see most common. I see it every single day. So it's like, I love any type of non-specific low back issue. I love discal. I love radiculopathy. I mean, it's like you see it all the time. So it's like if you don't get good at it, your practice is going to suffer. So it's an area that you got to know a whole lot about because that's going to be the most common issue that you are going to see by and far. So the question I've got: can we talk about fascia at all or not?
It's actually a few minutes after
Yeah,
6, so we could actually defer that.
Okay.
So,
That's
yeah.
it.
Well, as we wrap up, again, can I just emphasize the process here? It's not about the answer. So all these questions, no matter how broad they are or how specific you can get, there is no answer. And I think in PNMT, that's what we want to foster is the process and problem solving. So maybe a round of applause for these guys up here on our panel.